and I would like to introduce Dr. Shakir Bahzad. Dr. Shakir Bahzad, he is one of my colleagues at the Kuwait Medical Genetics Center, and they found this is a good opportunity for us to clarify some of our works that, although it's not published, but maybe later I will clarify our work. But Dr. Shakir Bahzad is a clinical and molecular geneticist at Kuwait Medical Genetics Center and Kuwait Cancer Control Center at the Ministry of Health. He achieved his MBBS from Kuwait University and went to APCP at University of Saskatchewan, Canada, and then genetics at McMaster University, Ontario, Canada. His talk will be Hereditary Cancer Clinic, a Geneticist Perspective. Please, Dr. Cancer, you have the platform.
Hi, hello. Right, okay. Just share my screen. Okay, so is it clear? Okay, so my name is Shakir Bahzad. I'm a clinical geneticist, and I divide my time between the Kuwait Medical Genetics Center and the Kuwait Cancer Control Center. This is my disclosure. So after the beautifully intense lectures we had so far, I'd like to shift gears to the clinic itself. So I'm going to take you in a journey that the patients with possible hereditary cancer syndrome go through in Kuwait, from referral to the follow-up. So just a quick note before we proceed further. Cancer predisposition syndromes are a lot, and it's a very long list. Since BRCA1 and 2 comprise the most common ones, found by far most common ones. So I'm going to use them as a model, and you can apply that model with a bit of tweak to other cancer syndromes. So just a quick word about BRCA1 and 2. So these are the twin genes everybody knows. Just like any twins, if you see them from afar, they're indistinguishable from each other. But when you look closer, you will find those subtle differences between the two. So, for example, BRCA1 is associated with a higher risk of breast cancer compared to BRCA2, and BRCA2 associated with a higher risk of ovarian cancer compared to BRCA1. And there are other cancers that are more associated with BRCA1 compared to BRCA2, and vice versa. Quick word on the epidemiology of breast cancer and ovarian cancer. So any female born today, so from age 0 till age 85, so in her lifetime, there is around 12% chance of developing breast cancer, plus minus 1%. Of those, we expect 5 to 7% to harbor BRCA1 or 2. However, for ovarian cancer, the lifetime risk is much lower, which is around 1 to 2%. And of those, we expect 15% of them to harbor either BRCA1 or 2. And there are many other cancers associated with BRCA1 and 2. It's not just breast and ovarian, such as male breast cancer, prostate, pancreas, melanoma, gastric, you name it. It's there. The list is very long, but the association becomes less and less, and the risk becomes less and less as you go along that list. The male breast cancer usually is overlooked by many physicians. The lifetime risk of getting breast cancer in a male is 1 in 1,000, which is 0.1%. However, this number jumps to anywhere between 1 and 2% with BRCA1. You might think that 1 or 2% is not that high, but it's compared to the original number, it's around 10 to 20 folds. And the number is even higher with BRCA2 that actually goes up to 10%, which is 100-fold the original general population risk. So just a quick word on the guidelines. So I find it very practical if you choose one or maximum two guidelines and you stick to them throughout the patient's journey. This is just an example, and this is from the American College of Medical Genetics and Genomics. This is just a snapshot of the breast cancer section, and it's a little bit more oriented towards the pathological diagnoses. Whereas the NCCN guidelines, which is more comprehensive, and this document actually that talks about hereditary breast and ovarian cancer is around 120 pages long, and it details the whole testing process and going through the management. So this is just a slide, the snapshot of the testing criteria that should be considered. This is actually just the first page of this criteria, and the criteria actually goes on and on. So it's a little bit difficult if you have your own practice as a primary doctor or a surgeon or whatever your practice is, to memorize all these and to keep them in mind in a busy clinic setting. So what I did is just I summarized those in seven points, taking into consideration the ACMG guidelines and the NCCN guidelines, and I found them to be very helpful with in a general setting in the primary care. So in your practice as a non-geneticist, if you come across a patient, or the patient tells you that she or somebody in the family had a breast cancer at the age 45 or less, she's eligible for a genetic counseling session. Also, if the pathological type is triple negative, the age is extended to less than 60 years. Bilateral cancer or multiple breast cancers in the same person and in the same breast. So synchronous bilateral breast cancer or metasynchronous bilateral breast cancer. Also, if the family has at least 3 or more related cancers to BRCA1 and 2 on the same side of the family, if the patient herself or himself or other members of the family have 2 related cancers, 2 primaries, and also if the patient has ovarian cancer, that's on its own right is one of the indications for referral, or somebody close, first degree or second degree or even third degree in our region with ovarian cancer. Individuals with a male breast cancer and individuals who are known either somebody who's close to the patient or cousins known to have a pathogenic mutation in either BRCA1 or 2. So if you see if you see any of those, this patient and the family deserves to be seen by the genetic services. So what happens is we have our own website for appointments for the genetic center. It's an easy, just single page, and it's in Arabic and in English, and they can just fill in the boxes, and then they can get an appointment. So it's we're trying to make it easier to be reached because the Medical Genetics Center is the only center in Kuwait and serves around 4.5 million people. So we're trying to make it easier for patients to reach us. So we usually see the patient at least twice, so pre-testing and post-testing counseling sessions. And as Maya said before, I can't emphasize enough the importance of the genetic counseling session to be done by somebody who's experienced in cancer genetics. I can't tell you how many times that I've seen patients and they are referred from somewhere else, and their physician or their caregiver, their health caregiver took a stab at counseling and ended up in misconceptions and misunderstandings. So it's important to be referred to somebody who is specialized in cancer genetics. And usually in those sessions, we talk about the appropriateness of genetic testing, whether the patient is eligible or not, and why. We go through all the possible outcomes, whether it's positive, negative, or uncertain significance, and sometimes these tests might not be informative. And we dedicate a certain chunk of our time for the psychological risks and benefits of genetic test results, because I find this part that's the most overlooked by patients and their primary physicians. And once we start talking, once we start explaining the psychological risks, they pause and they think about it more. And of course, the mode of inheritance and expressivity of the disease and so on. And explaining, sometimes we explain certain technical parts of the test itself. So at the Hereditary Cancer Clinic, so the pre-test counseling session, these are the most important parts that we go through. So the history of present illness, and it's usually and the past medical history, but it's usually focused on cancer history, and of course the detailed pedigree and the eligibility of the testing discussion and why she or he is eligible for testing or not, and the risk calculation, which I'm going to go into in a minute. So the history of present illness and the past medical history, this is the focused part of it. And these are the questions that we usually go through. So does the patient have cancer or not? Whether now or the patient is a cancer survivor. What type? Usually we look for the pathological type, not just breast cancer. If I can get more details, whether it's lobular breast cancer, or it's invasive ductal, or so on, it would help a lot. And at what age it was diagnosed, not the current age of the patient. No, at when the patient actually realized for sure that this is cancer, not when they started feeling the lump. No. When somebody stuck a needle there and took it, and we looked under the microscope and we said that this is definitely cancer. And how many primaries? You'll be surprised. You see like a 40-year-old. She tells you that she got breast cancer like a couple of years ago. But when you dig deeper, she tells you, I got something like ALL when I was 5 years old or something. So it's usually it's worth going deeper. Pathology reports, if they are available, that they help. Whether the patient received chemo or radiotherapy, because this sometimes, if it's recent, sometimes it messes up the DNA. The DNA, when you take it, it's a bit degraded, and the test might not be accurate. And any members of the family or the extended family had any type of genetic testing done before, and if we can get a copy of that. So this is a fictional pedigree showing a typical cancer pedigree, and this is our patient with the arrow here pointing at the proband. So Allison here had breast cancer at age 28. So on her own right, she deserves to be referred to genetic services. But if you go further, her mother had breast cancer at age 58, and also her maternal aunt got ovarian cancer at age 61. So we satisfy one criterion here, and we satisfy another criterion because of ovarian cancer in the family, and we also satisfy a third criterion, whereas we have three members of the family with related cancers on the same side of the family. And she might have actually satisfies more if we have the pathology report of this guy who had pancreatic cancer at 60. The pathology of the prostate cancer actually makes a difference. So we say that this family is eligible for genetic counseling and possibly testing. So either the patient is eligible for testing and then we offer the test and we talk about the test and we defer risk calculation to the next visit, or the patient is not eligible for testing and we discuss the risk calculation, which I'm going to talk about now. So the risk calculation, this is only designated for breast cancer risk. So there are many software models. They are free, they are online, developed by statisticians and mathematicians, and they are great tools. Many of them are validated over and over. And with experience, I feel that they actually provide invaluable information. So this is just one of them, which is the IBIS, and this is just the interface, and it's available online and it's for free. I do, however, recommend that it's done by somebody who has a background in cancer genetics rather than the primary physician. You fill in the interface and then the evaluation screen, and then it builds a pedigree by itself, and there are other tabs that you have to go in and fill in the blank, and you can integrate the if a test was done, and so we can integrate the BRCA1 and 2 testing into the software to give you a more meaningful result. And this is what the software spits out: a 10-year risk for breast cancer, and compared to the general population with matched to that patient, and of course the lifetime risk of that patient also matched to the general population. And if you do not plug in the BRCA1 or 2 results, it will give you the possibility of this patient harboring a BRCA1 or 2 mutations. So this is back to the NCCN guidelines, and this is the page where for the management. Again, this is just the first page, and it actually goes on for several pages, and it's detailed and with multiple links. And again, it would be much beneficial for the patient to be done by somebody who has experience with and a background with managing BRCA positive patients. So if the patient, when the patient is deemed as high risk for breast cancer, so either if the patient has BRCA1 or 2 mutations, or any of the other genes that I'm going to mention later on, or if the patient is negative, but by calculation reaches 25% risk or more, because not all breast cancer are related to BRCA1 or 2 or the related genes. So if they reach 25%, regardless of their genetic testing, we will consider them as a high risk, and they will be enrolled into the high risk surveillance program, which includes the yearly MRI and yearly mammogram. It depends on the age and circumstances. So just quick words on other syndromes associated with either breast or ovarian cancers. So Li-Fraumeni syndrome with the TP53 gene mutations is associated with breast cancer at the age of less than 30. And we have a couple of families that we follow up in Kuwait. Also Cowden syndrome with a P10 gene mutation. This is primarily hamartoma disease. However, when it comes to malignancy, it's associated with, on the top is breast cancer with a very high risk of around 85% found in the literature. Hereditary diffuse gastric cancer, this is a very rare but potentially devastating syndrome to have, and they usually see the family primarily having either gastric cancer, the diffuse type, this is the pathology type, and specifically lobular cancer of the breast, not ductal carcinomas. Also, puts Jaggers with this STK11 gene also is associated with increased risk of breast cancer. Now with Lynch syndrome, which is the second common cancer predisposition syndrome in our region after BRCA1 and 2, there are many publications on the association between Lynch syndrome and the risk of breast cancer. However, these are very conflicting data, and some of them say yes, some of them they say no. So currently, for patients with Lynch syndrome, we just advise them. Of course, it depends on their family history, but I usually advise them to follow the surveillance for the general population concerning breast cancer. However, it is associated with increased risk of ovarian cancer. So this is how we divide patients in terms of management. So this column is the non-surgical option for the follow-up, and these two are the surgical options. This one is for breast, and this one is for ovarian. So if we have one of those genes, if the patient selects opts for non-surgical option for follow-up, this is what, and she has one of those genes, this is what we do here. However, if it's BRCA1, there is no sufficient evidence for intervention in terms of risk of breast cancer. However, it is associated with increased risk of ovarian cancer, so we recommend and consider risk-reducing salpingo oophorectomy in our post-testing discussion session. And also, these are the genes currently we discuss. If we have one of those, we discuss the option of risk-reducing mastectomy, which is double mastectomy with reconstruction. So think of the BRCA1 and 2 as the Grady twins, the evil twins from The Shining. So from far away, they look like each other, but if you go closer, you will find some differences. There is no BRCA3, but PALB2 comes close. Really, I should have put like the evil triplet. But when I Googled evil triplet, it took me to places on the internet that I shouldn't be visiting. So finally, what the referring doctor will get back from us is the following. So this is what we include in our letter. So the past and medical history focused on cancer, a copy of the pedigree that the detailed pedigree that we did, the risk assessment, and the explanation, whether the patient is eligible or not, and whether the patient had the test, and explanation of the test, and of course a copy of the test will be attached, and the results will be attached, and the summary of the genetic counseling session, along with recommendations and our referrals if the patient selects to see surgeons or plastic surgeons for possible risk-reducing mastectomy. So, and by that, I end the journey. So thank you for your attention. This is our website for the appointments. This is a free website that you can go and it's for you can create an account for free, and you can establish your own appointment clinic in that one. And this is my my email if you have any questions. Thank you.
Thank you, Dr. Shakir, for your lecture, and thank you for giving me 5 minutes to clarify some of the points that were in the lectures before. Dr. Mona, if you allow me these 5 minutes, which I think it's belong to Kuwait Medical Genetics Center. First of all, I'd like to clarify that Kuwait Medical Genetics Center established at 1978. And since that time, we have all the available tests that were available at that time. The cytogenetic, then after that came the FISH, and after that the microarray, and now we have the next generation sequence. Maybe we are lazy in publication, but really we have all the service. We have the premarital counseling since 2008, which is mandatory for all marriages. We have the screening since 2013 by law. And before that, it was in some hospitals. Now it's in all Kuwait. For example, I will give you that we received in our next generation sequence lab 3,072 sample, 827 for whole exome sequence, and 2,245 for panel test. And we have a 17% pathogenic result, 14% likely pathogenic, and 24% insignificant, and 45 were negative. So maybe, as I said, we don't publish a lot, but we have the service in Kuwait. All the services are available, free. It's a governmental, paid by government. So really, I'd like to clarify these points. And I hope in the near future, you will find our publication in all the journals. Thank you, Dr. Muna, and we can go, I think, to the questions.